So right now, the ED is pretty locked down with bed holds. Usually 30 people in the waiting room. We've got 15 bed holds. Is it safer for your patients to hold people back and have them sit in a hallway bed or sit out in the waiting room? Because you're going to overwhelm your nursing staff if you have hallway patients and they're not going to be taking care of the admitted patients that are boarding in the ED. So can you talk about how to manage that?
All right. So the question is it, to summarize, is it better to, in a bedlock situation, to bring is it better to let the patient sit in the waiting room or bring them back and let them sit in a hallway bed if there is no available acute care beds?
So
I'll let you start.
Opinions on this. I'm trying to research bed holds and bad outcomes of folks, and it's very obvious that when the ED fills up with inpatient holds, bad stuff happens. We're just trying to prove that a little bit more fully, and Jim's helping me with this right now, as well as Chris. So that's obvious. The question is, what do you do about it? And I'm a much bigger fan of geography should not determine your care. So if you're in the waiting room and you're really full in the ER, I say you pull them back. If you have to put them in a hallway, if they're, if you're putting 2 in a room, if you're putting people on the ped side, whatever you got to do to actually get that care delivered to them, I think you should do it. Is that ideal? No. Are you going to miss stuff? Absolutely. We know that we can't do a full physical exam and have somebody undressed in the hallway. You just can't do it. So if they're presenting with hip pain and you're like, well, you're in a hallway bed, I'm probably not going to actually see the skin on your hip very well unless I make a lot of effort to do so. And you just have to know that you're practicing risky medicine. But I think that that is much better than leaving them in a waiting room not seeing anybody. Now, that is a controversial thing. And so I definitely respect folks that say, look, I can't do my proper exam. The nurses are overtaxed. If we push them over the edge by putting all these often lower risk or lower acuity folks in hallways, then they're not going to be able to take care of the sick folks. And I get that. But I would much rather them be seen by a provider so that at least they have the opportunity of you laying eyes on them and figuring out they're sick. Because not infrequently, some of those folks you pull the hallways, you're like, actually, I want to work you up for PE. That little, pleuritic chest pain that was a level 4 is actually really legit. And so there's a lot of those folks that actually need real workups. And I would rather cut that time down to seeing them. But what do you think, Rich?
Let me real quick. I'll just say that I'm biased because where I trained at Detroit, there was no. We did not use the waiting room. They came straight back. All right. They passed by triage that they need to go to critical or can they go to acute. Either case, they came back, and when we ran out of beds, they sat in chairs, and when they ran out of chairs, they sat on the floor. Now there is a trade-off in that the nurses get overtaxed as well as the physicians get overtaxed. But I think that the nurses that I worked with would agree that we were able to pick out patients who were very sick subtly that would have traditionally been sitting out in the waiting room. So they moved up our radar and our priority list just by allowing us to lay eyes on them and have a short exchange with them. Alternatively, we could turn around some people very quickly too and get them out. But I think the big caveat is you get your eyes, the big advantage is you get your eyes on all your patients quicker. So I kind of like the bring them on back approach, and again, that was the way I was trained. LaShawn?
I feel like the problem here isn't so much whether or not we want to do it, it's the nurses saying, no, I can't, no, you can't. It all depends on which nurses are on at whatever time you're trying to do it. And if that's that big of an issue, are there not seasons where it would be more cost effective to flex up the nurses or have an on-call person that you call in for that very reason so that we can burn through, we're not having the waiting room with 25 people in it, at 3 o'clock in the morning, which in this ED shouldn't be the case,
Right.
So LaShawn brings up a great point there about nurses appropriately, I think, saying, look, I can't handle 8 patients. Like, that's way too many, and it's not optimal. And if you actually pull the full, if you do the Detroit model or the Dan, pack the ER with as many people as you humanly possibly can, you're going to overwork your nurses. And that's going to cause less care for those folks than if they had just 4 patients per nurse. Amal Mattu does a great lecture about the Cheesecake Factory, which is really entertaining, saying, look, the Cheesecake Factory knows exactly how many people within a few percentage point are going to come eat on Saturday night. They're never surprised. They never run out of cheesecake because they're the Cheesecake Factory. They can't do it. You would find it ridiculous if you went to a restaurant like, hey, I want this, and they're like, oh, we're out of everything on the menu because we didn't expect for 20% more people to show up today, and you would leave. And for some reason, the ER is largely staffed the same, whether it's Tuesday night or Saturday night or Wednesday morning. Like they basically have this fiction of people come roughly the same per day of the week. And it's just not true. We all know that Monday is crushing and that maybe Saturday afternoon is not too bad. Like we all see that. Yet the staffing doesn't flex that much. And so it's really complex to figure out how do you make it so that people don't have a horrific call schedule where they're on call for like 3 weeks a month. You know, where they could be called in at any moment, yet still offer that flex of, look, we need an extra 3 nurses, or maybe we need an extra doctor. You know, those are really controversial things of like, how do you do that without killing everyone's quality of life? Because I want to have a beer and go travel and stuff like that, and I can't do that if I'm on call all the time. So how do you balance that of realistically pulling someone and say, look, we're getting killed, it's Monday night, I want another ER doc to come in. Like, that would be great, but a lot of places aren't really able to do that yet. I think I saw you.
Same topic, different scenario. Single coverage with only 2-3 nurses, 10 sick patients, and 2 of them code. Who's to blame? Is it the physician medical legally, or does it have to do with the hospital?
It's always your fault. It's like no matter what, it is your fault. If they code in the parking lot and you never saw them, it's probably your fault. Like it's always.
So 10 single coverage, 10 sick patients, 2 of them code.
Yeah,
I don't think that's anybody's fault. That's just an unfortunate scenario.
Yeah, I just didn't know if something bad.
Thanks God.
Would what? Medical legally? Is that what you're asking?
Medical legally, I mean, can you defend yourself saying that night we had less nurses than we were supposed to? We had a very busy ER. We couldn't turn people away due to EMTALA, and we had 2 people that got sick at the same time.
Yeah.
I don't think you have an medical risk for that.
You're probably fine.
So I think
very few emergency physicians, they're going to have a very hard time, or plaintiffs attorney would have an extremely difficult time finding a reliable, credible witness that would testify against you if you had 2 people coded at the same time. You're not breaching the standard of care. You didn't cause that, unless you somehow caused the people to code at the same time.
But I think the question, digging a little deeper, is a very good one, and I think what you're asking is, should you document that the situation was an unfortunate situation, or is that what you're trying to say? Would that protect? I think you got to be careful with that, actually, because it could be twisted as though you're an emergency physician. You're supposed to be able to handle distress. I mean, I think it could be twisted as, kind of whining a little bit. And so, I mean, if there's an extraordinary circumstance where a bus rolled over or whatever, I mean, that's one thing. But 2 codes happened in the emergency department, not irregularly.
Right.
So to then sit there and say, well, I had 2 codes, so I just let one of them go, or what? I don't know. I don't know where you go with that. I think you'd have to be really careful with that, actually.
So I think that your risk would actually be fairly low because technically you're experiencing a disaster in that. So remember the definition, you've got more needs than you have resources to provide.
You may do damage by documenting around that.
So you've got a single coverage ER, and it having worked at a single coverage ER a lot, it's not uncommon out in the community because most places have 1, maybe 2 docs, and stuff happens where 2 sick folks show up or 2 codes happen at the same time a lot. But I think that the key here is you do the best you can. I think that you document appropriately that, look, we tried what we could. I don't think there'd be a problem saying, look, I was coding another person at the same time, but you got to be really careful that you don't say, it's okay for this guy to die because I was taking care of this other one. That would be a poor choice. But
I just wouldn't drag it on, is what I'm saying.
Trinity has run the codes upstairs. I mean, that's the whole another thing, too. You have different levels.
That's a medical legal nightmare. If you're ever at a shop, and this is something for you guys, especially third years, to be aware of, if you go to a place that says that you're supposed to run the inpatient codes, it is a medical legal disaster waiting to happen. Because you physically cannot be at both places. And so if you're up there coding someone on the 3rd floor, you cannot watch your folks. And there will be a time, it's just a question of how long does it take, when you have a sick person downstairs and a sick person upstairs, and you are hosed. Because one of those people is going to do poorly, and understandably, the family is going to be upset. Like, what do you mean you didn't come up to code my patient? The fact that you've got a sick asthmatic that you're intubating downstairs really doesn't enter into their calculations very much. And it looks really terrible on you. Like, I didn't even go upstairs. But I think that it is okay to have nurses run codes while you're seeing another patient. If you have to tube somebody, ACLS is not that hard. And so just saying, look, continue compressions, I want you to push epi every 5 minutes. I'm tubing this guy, I'll be right back. I think is a very appropriate strategy in that.
Dr. Gross had a comment.
I was just going to add on, probably what's worthwhile documenting someplace on a recorded line is if you talk to someone to say, I need help because I'm moving into disaster mode. I need to diversion, or I need additional help. We can't keep letting more patients come in here. I'm now making the administration responsible for this decision.
Yeah.
I think that's a great point, because your chart's going to look so much better if you say, look, this mass casualty thing happened and I got 4 sick trauma folks, and I called my administrator and asked them to call them back up. And if they don't do it, you've really very successfully passed the buck of I'm doing the best I can here. I asked for help and I didn't get it. It may be that help's not realistically coming in the near future, and you just got to be ready for it. A couple X's.
All right, 2 X's. Was it a different question?
No, it's kind of related to that.
All right, well, the 2 X's, I'm just kidding. Go ahead.